is a complete review of mental health nursing for NCLEX-RN exam, divided in 7 sections.
All right, whether you're a seasoned pro or just diving into psych nursing, welcome. We are about to do a super fast run through of the absolute must-know concepts in mental health. This is the stuff that really matters, the high-yield info you're going to use every day. So let's get right into it, shall we? Okay, to kick things off, I've got a question for you, and I want you to really think about it. What is the single most important tool we have in mental health nursing? Let that sink in for a minute. What do you think? I'll give you a hint. It's not some new medication, and it's definitely not a fancy machine. So what is it? Well, it's something way more fundamental. We're going to get to that answer in just a second, but first, here's a quick look at where we're headed. First up, we'll tackle that foundational tool I mentioned, building the therapeutic relationship. From there, we'll jump into navigating mood disorders. Then we'll try to decode schizophrenia, get a handle on anxiety, and wrap things up with understanding personality disorders. Ready? Let's do this. Okay, so the big reveal, that single most important tool, you got it. It's the therapeutic relationship. It's you. It's that connection you build with your client. That right there, that's the absolute foundation of everything we do in mental health care. Now, this relationship doesn't just happen by accident. It's actually a pretty structured process with 4 key phases. It all starts with the pre-orientation phase. This is your homework time, right? Before you even say hello, you're looking at the chart, getting prepared, and this is huge. You're checking in with your own feelings. Then you move into orientation. This is where you meet, you start building that trust, you set boundaries, and you figure out what you're going to work on together. After that comes the working phase. This is the real meat of it all, gathering info, practicing new skills, and seeing how things are going. And finally, you get to the termination phase. Here, you're wrapping things up, looking at all the progress made, and getting ready for discharge. And you know, this last step is super important to handle carefully because it can be a really tough time for the client. Okay, let's talk about 2 huge concepts that you absolutely have to understand because they can either make or break that therapeutic relationship. We're talking about transference and countertransference. So, transference, that's when the patient starts redirecting feelings they have about someone from their past onto you, the nurse. Maybe you remind them of their critical mother or a kind teacher. Now, countertransference, that's the other side of the coin. That's when your stuff, your past, starts influencing how you feel about the patient. Spotting this in yourself is one of the hardest but most important skills to learn. It's what keeps you professional and effective. So how do we actually build this relationship? Well, it all comes down to communication. Let's look at some of these key techniques. You've got your broad openings, simple things like, what's on your mind today? It lets them lead. Then, open-ended questions. Instead of yes or no, you say, tell me more about that. It gets them talking. Sharing observations is another good one. I notice you seem a bit down today. It shows you're paying attention. Clarification is just making sure you're on the same page. So what I hear you saying is, and this last one, presenting reality, is so important with psychosis. You validate their experience. I understand you're hearing voices, but you gently state your own reality, but I don't hear them. It's a tricky balance, but it's crucial. Okay, so now that we've got our communication toolkit, let's put it to work. We're diving into our next big topic, the highs and lows of mood disorders. This slide lays it out perfectly, the 2 extreme poles. On one side, you've got acute mania. Think of it like a gas pedal stuck to the floor. Tons of energy, rapid-fire talking, feeling like you're on top of the world, but with really poor judgment. Then, on the complete opposite end, you have major depression. The energy is gone, there's no interest in anything, that's a key word, anhedonia, and just this feeling of complete worthlessness. These 2 states are worlds apart. Your job as a nurse is to be a detective, watching for the subtle shifts between these poles, because that tells you the care plan might need to change. So when someone is in an acute manic state, what do? 2 words, safety and structure. That's your mantra. First, you've got to dial down the environment. Less stimuli. A private room is ideal, somewhere you can keep a close eye on them. You want to limit big group activities. One-on-one is much better. And eating, they're not going to sit down for a meal. So think high-calorie finger foods they can grab while they're moving. Getting them to do some physical activity is also a great idea to help burn off some of that intense energy. And above all, you have to set firm, consistent limits. This is non-negotiable for keeping everyone safe. All right, we have talked about the extreme poles of mood. Now, we're going to shift gears to something that can be really complex, trying to understand the altered reality of someone with schizophrenia. You know, a lot of people think schizophrenia is just about psychosis, but it's so much more than that. This chart breaks it down really well into 4 different types of symptoms. First, you have the positive symptoms. That's the psychosis stuff. Then you have the negative symptoms, which are about what's missing. You've also got cognitive symptoms that mess with thinking and memory. And finally, there are often mood symptoms, like depression and hopelessness. And here's a super simple way to keep positive and negative symptoms straight. Think of it like math. Positive symptoms are things that are added to reality, things that shouldn't be there, like hallucinations or delusions. Negative symptoms are things that are subtracted or lost, things like a loss of emotion, we call that a flat affect, or a loss of motivation, or even the loss of the ability to feel pleasure. So just remember, positive means plus, negative means minus. Simple as that. One of the most telling positive symptoms is disorganized speech. It's like the wiring in the brain for language gets all crossed, and thoughts just come out in a jumble. The best way to get this is to see it in action. So we're going to do a quick, rapid-fire round of examples. Ready? First up, neologisms. These are just made-up words. They mean something to the person saying them, but to nobody else. Like, the Vulmers are coming to execute me. What's a Vulmer? We don't know, but to them, it's a very real threat. Okay, next we have clang associations. This one is all about sound. The person chooses words because they rhyme, not because they make any sense together. Let's go to the bay, let's hit the hay. What do you say? It's all about the rhyme, not the reason. And last one, word salad. This is exactly what it sounds like. Words are just thrown together in a random jumble, like ingredients in a salad. Here is the chair, moon, orange, drink too much. There's zero connection, zero logic. The sentence structure has completely fallen apart. So we've just seen how thinking can get scrambled. Now let's switch gears and talk about how feelings can get completely overwhelming. We're moving on to anxiety and how it can range from just a little bit of worry all the way to a full-blown phobia. Let's talk about a big one, generalized anxiety disorder, or GAD. It's really important to know this isn't the same as everyday stress. We all worry. But GAD is when that worrying is constant, it's excessive, it lasts for at least 6 months, and it starts causing real physical problems, like being exhausted all the time, muscle aches, and not being able to sleep. So what do we do about it? Well, if the anxiety is mild or moderate, we can teach coping skills, right? Things like recognizing the triggers, doing some deep breathing. But, and this is a huge but, when anxiety hits that severe or panic level, all that teaching goes out the window. Their brain just can't problem solve anymore. Your entire focus has to shift. It becomes all about safety. You use short, simple sentences. You stay calm. You just be there. Honestly, in that moment, your calm presence is the best tool you have. You become their anchor. All right, for our last section, we're going to pull the camera back a bit. We've been talking about these intense, acute states like mania and panic. Now we're looking at personality disorders. The key here is that these aren't temporary states. They are long-term, deeply ingrained patterns of behavior that really affect how a person sees and interacts with the world. This table is a lifesaver for organizing the 10 different personality disorders. They're broken down into 3 groups or clusters. Cluster A is your odd and eccentric group. Cluster C is the anxious and fearful one, but the one you'll probably encounter the most is Cluster B, the dramatic and impulsive group. This is where you find disorders like borderline and narcissistic. And a quick pro tip for Cluster B, the entire healthcare team has to be on the exact same page with boundaries. Consistency is everything. Okay, let's drill down on one specific concept that you will definitely see, especially on exams. It's called splitting, and it's a hallmark of borderline personality disorder from that Cluster B. Think of it as black and white thinking. There's no gray area. To the patient, you are either a saint or you are a monster. One minute you're the best nurse they've ever had, the next they hate you. And this is exactly why that unified team approach is so critical. The team's consistency provides the stability that the patient can't create for themselves. Post-traumatic stress disorder, or PTSD. We're going to break this down so you know exactly what to look for and how to answer those tricky NCLEX questions with total confidence. So let's jump right in with a classic NCLEX-style scenario. Imagine this. You're on your unit, and a combat veteran in your care starts experiencing a flashback. They're reliving something terrible. What is your absolute number 1 first priority action? Just keep that question in the back of your mind as we go through this, because I promise, by the end, the answer is going to be second nature. All right, here's our game plan. We'll start with what PTSD actually is, then we'll break down the 4 key symptom clusters you need to know. After that, we'll get into our priority nursing assessments, interventions, and the treatments before wrapping it all up with the biggest takeaways for your exam. Okay, so first things first, let's build a solid foundation. What are we really talking about when we say someone has PTSD? So here's the textbook definition. PTSD isn't just a reaction to a bad day, It stems from exposure to a truly terrifying event, something that involved or threatened death or serious harm. And while we often think of combat, it's so important to remember this can be a natural disaster, a bad car accident, a physical assault. The core concept here is trauma. I love this analogy because it just makes so much sense. We all have that built-in fight or flight system that kicks in when there's real danger. Well, for someone with PTSD, it's like that internal alarm switch gets stuck in the on position. Their brain's fear center is just constantly overactive. So even when they're perfectly safe, their body is still flooded with stress hormones, making them feel like they're in danger 24/7. Now write this one down because this is a classic NCLEX distinction. It's all about the timeline. If someone experiences these symptoms after a trauma, but they resolve in less than 1 month, we call that acute stress disorder. But if those same debilitating symptoms hang around for more than a month, that's when we're looking at a diagnosis of PTSD. That 1-month mark, that is the magic number you have to remember. Okay, so let's get into the nitty-gritty of the symptoms. They're grouped into 4 main categories, or what we call clusters. Knowing these clusters is absolutely essential for spotting PTSD in those exam questions. And just a little heads up here, this is a classic select all that apply, or SADA question. The NCLEX absolutely loves to test your knowledge of these signs and symptoms, so pay close attention to these next few slides, because you are definitely going to see this again. Okay, first up, we have cluster 1, intrusion. And it's exactly what it sounds like. The trauma keeps intruding on the person's present-day life. And we're not just talking about a bad memory. We're talking about really distressing recurrent memories, horrible nightmares, and most intensely flashbacks, where the person feels like the traumatic event is happening all over again, right here, right now. All right, next is cluster 2, avoidance. Because those intrusive memories are so incredibly painful, the person will start doing anything and everything to avoid being reminded of the trauma. This could mean avoiding certain thoughts or refusing to talk about it. But it can also be really physical, like a person who was in a bad car accident who just stops driving completely. Cluster 3 gets into the negative changes in a person's thoughts and mood. The trauma can literally poison how they see themselves and the world. They might start to believe things like, I'm a bad person, or no one can be trusted. A huge symptom you need to know here is anhedonia. That's the inability to feel joy or any positive emotion. It makes people feel really detached and alone. And finally, we have cluster 4, hyperarousal. This brings us right back to that stuck-on fight or flight switch. Their nervous system is just in a constant state of high alert. This looks like being super jumpy, having a huge startle response, always being irritable and having trouble sleeping or concentrating. They are just completely exhausted from being on guard all day, every day. Okay, we know the symptoms. Now for the most important part for the NCLEX. Application. When you have a patient with PTSD, what do you, as the nurse, assess first? Because on the NCLEX, prioritization is everything. So your assessment has a very clear order of priority. Step 1, first, last, and always is safety. You have to assess for any risk of harm to themselves or to others, period. Once safety is established, then you can move to step 2, looking for unhealthy coping mechanisms like using alcohol or drugs to numb the pain. And finally, step 3 is working with them to identify their specific triggers. So now that we've assessed, let's talk about what we actually do. Our interventions are all about creating a safe, trusting, therapeutic environment. This right here, this is your script. You need to remember that during a flashback, your patient isn't really in the room with you. In their mind, they are back in the trauma. Your job is to be their anchor to the present moment. You use these kinds of calm, simple, grounding phrases to orient them and reassure them that they are safe right now. This slide is basically your nursing care plan in a nutshell. Building trust is the foundation of everything. Creating a calm, quiet environment is huge. And, one of the most therapeutic things you can do is simply stay with a patient during a flashback so they know they're not alone. Oh, and a massive safety point for the NCLEX. Because they startle so easily, you always announce what you're doing before you touch them. Always. As nurses, it's also our job to be familiar with the primary treatments our patients are receiving. And for PTSD, that usually means a combination of specialized therapy and medication. Now, these aren't just regular talk therapies. They're highly specialized. For example, trauma-focused CBT helps patients challenge and reframe those negative beliefs caused by the trauma. EMDR uses things like eye movements to help the brain reprocess traumatic memories. You don't have to be an expert, but you need to recognize these names for the test. And of course, group and family therapy are so important for that support system. When it comes to meds, this chart is your go-to study guide. The first-line medications are antidepressants, specifically SSRIs like sertraline and paroxetine. The key teaching point? Tell your patients it can take several weeks to feel the effects. And here's a special one to know for the NCLEX, prazosin. It's an alpha blocker, and it works wonders for those trauma-related nightmares. Just make sure you're monitoring their blood pressure for hypotension. Okay, this is a massive NCLEX safety alert, red flag. While you might think a benzodiazepine would be great to calm an anxious patient, they are generally avoided for long-term PTSD treatment. Why? Because they have a super high risk for dependence, and they can actually get in the way of the trauma-focused therapies working properly. So be really, really cautious if you see a benzo as an answer option. Phew, okay, we have covered a ton of ground. So let's boil it all down to the absolute must-know information for your exam. Think of this as your final rapid review. All right, let's lock these in. Number 1, safety is always the priority. Assess for risk. Number 2, during a flashback, you stay with them, keep them safe, and use grounding techniques. 3, for communication, validate their feelings, but never, ever force them to talk about the trauma. 4, meds, SSRIs are your first choice, and prazosin is for nightmares. And 5, the timeline. It's PTSD if symptoms last longer than 1 month. If you can remember these 5 pearls, you are in fantastic shape. So let's circle all the way back to that first question about the combat veteran. What's your priority? By now you know. It's ensuring their immediate safety, staying with them, and using that calm, grounding communication. And that brings us to this final thought. When your patient says something like this to you, what does that statement indicate? It shows progress. It shows that they're using healthy coping skills instead of avoidance. And that is the whole goal of our nursing care. Recognizing that progress is key. You've got this. Happy studying.
Okay, so here's our plan for today. We're going to talk about coping mechanisms, then we'll jump into crisis management, move on to grief and loss, and finally we'll cover the really big one, depression and suicide prevention. We'll wrap it all up with a quick review of priority actions for your exam.
First up, let's talk about the bedrock of so much of what you'll encounter in psych nursing, and that's defense mechanisms. Honestly, if you can get a handle on these, you'll be so much better at understanding why your patients act the way they do under stress. It's really the key.
So what are they, really? Think of them as the mind's automatic self-defense system. When anxiety hits, these tools just kind of pop up to protect us. Sometimes we know we're using them, but a lot of the time this is all happening completely under the surface. Let's go through the big ones you'll definitely see on the NCLEX. Okay, first up is a classic. Denial. This is that gut reaction buffer against news that's just too much to handle at the moment. You'll see this a lot. A patient gets a new cancer diagnosis, and their first response is, "No way, that can't be right. You must have the wrong chart." Their mind is just refusing to let that painful reality in.
All right, next is displacement, and this one, you will see this all the time. Picture this. The doctor gives a patient some bad news, walks out, and 5 minutes later, that same patient is yelling at you about their cold food. Is it about the food? Of course not. It's so important to remember, it's not personal. You're just the safer target for the anger they really feel about their diagnosis.
Then we have projection. This is when a patient takes their own unacceptable feelings and, well, projects them onto someone else. So instead of admitting, "I'm so angry," they'll say, "My doctor is so angry with me." They're basically seeing their own emotions reflected back at them from another person.
Now, these two get mixed up all the time, so let's make this super clear. The big difference is awareness. Repression is unconscious. It's involuntary. The person doesn't even know they're pushing a memory down. Suppression, on the other hand, is conscious. You know that feeling you don't want to think about, and you actively say to yourself, "Nope, not dealing with that right now." That's suppression. You're making a choice.
Okay, NCLEX alert here. This is a really important point. Not all defense mechanisms are bad or maladaptive. Some are actually healthy. The best example is sublimation. This is when you take an unacceptable impulse, like aggression, and you channel it into something productive and socially acceptable, like becoming a star athlete. The NCLEX loves to ask you to tell the difference between these, so know this one. Okay, so now that we have a good foundation in coping, let's ramp it up. What happens when something big occurs? A crisis. A crisis is basically any event that just completely overwhelms someone's ability to cope, and that's where you come in. Your job is to be that stabilizing force.
You'll need to know the 3 main types of crises for the exam, because how you intervene might change. First, maturational crises. These are the stressful but normal parts of life, like having a baby or retiring. Then there are situational crises, the unexpected curveballs, like a sudden job loss. And finally, adventitious crises, which are those big traumatic external events, like a hurricane or a violent crime.
But here's the thing. No matter what kind of crisis it is, your priorities are always the same. And safety is always, always number one, yours and the patient's. Once everyone is safe, your goal is to help them regain a sense of control. We do that by lowering their anxiety and helping them tap into their own resources, what's worked for them in the past. Who can they call? That's what we need to figure out.
So a crisis happens, a loss occurs, and what follows, inevitably, is grief. This is such a fundamental part of being human. And it's so important to remember that as a nurse, your job isn't to fix their grief. You can't. Your job is to sit with them in it, to be that source of support, and to create a safe space where they can feel what they need to feel.
We've all heard of the 5 stages of grief, right? Denial, anger, bargaining. But here's the crucial thing to remember. It is not a neat, tidy checklist. People do not just go from stage 1 to stage 5 in a straight line. They bounce all over the place. They might be in acceptance one day and right back in anger the next. And that is totally normal.
It's also really useful to know that grief comes in different flavors. There's anticipatory grief, which is grieving a loss before it even happens, like with a terminal illness. There's complicated grief, where that intense sorrow just doesn't let up, even after a year. And then there's disenfranchised grief. This is the grief that people don't feel like they can talk about, like a miscarriage. It's incredibly isolating.
And all of this, unresolved crisis, complicated grief, it can lead us to our most critical topic. This is where your skills as a nurse become absolutely life-saving. We're talking about depression and suicide prevention. Your assessment here is everything.
So how do you assess for suicide risk? Let me be perfectly clear. You have to ask directly. This is not the time to be vague or beat around the bush. You must use the words. Asking, "Are you thinking about suicide?" doesn't put the idea on their head. It shows them you're a safe person to talk to about it.
And when you ask, you're looking for 4 key things. Think of it like a ladder of risk. The first step is ideation. Are they even thinking about it? The next step up is the plan. Do they know how they would do it? Higher still is means. Do they have access to what they need? And the very top of that ladder, the highest risk, is intent. Do they plan to act on it? The more specific their answers, the higher the risk.
Okay, write this one down. This is a huge NCLEX danger sign. If you have a severely depressed patient who suddenly seems calm, happy, or at peace, be very, very concerned. It can look like they're getting better, but what it often means is that they've made the decision to end their life. That decision brings relief, and with that relief comes the energy to actually follow through. It is a massive red flag.
So how do you talk to them? Use open-ended, empathetic statements. Instead of asking, "Why are you sad?" try reflecting what you see. "You seem to be feeling really hopeless right now. Can you tell me more about that?" And a major don't. Never, ever promise to keep it a secret. You just can't. You have a duty to report and to protect them. So, what's the #1 priority intervention? If that patient confirms ideation, a plan, the means, and the intent, what do you do first? You put them on a 1-to-1 observation, immediately. This means someone is with them, at arm's length, 24/7. It is not optional. It is the absolute priority to keep them safe.
Okay, let's pull all this together with a couple of easy-to-remember mnemonics. These are perfect for when you're in the exam and your brain feels a little fried. They'll help you lock in these priority actions.
When you're caring for a patient with depression, just remember the word SAFE. S is for stay with the client. Your presence is therapeutic. A is for assess for suicide risk, and you have to do this continuously. F is for focus on their feelings, and E is for engage their support system. And for a patient in crisis, think STEPS. S is for safety first, always. T is for talk calmly.
your tone matters so much. E is for engage help, don't try to be a hero, get your team. P is for provide reassurance. And the final S is for set limits, especially if their behavior is becoming unsafe. As you get ready for your exam and for your career, I want to leave you with this one question to think about. How are you going to balance the absolute non-negotiable need to maintain patient safety with the equally important need to provide compassionate, human, therapeutic care? Finding that balance, well, that's really the art and soul of psychiatric nursing.
All right, welcome everyone. We're about to dive into some of the trickiest pediatric psychiatric disorders that you're going to see, both on the clinical floor and, of course, on your exams. My goal here is to make this stuff feel way more manageable and a lot less scary.
You do this all the time, right? This is a classic clinical puzzle, and knowing the key differences is absolutely crucial, not just for passing the NCLEX, but for being a safe nurse. It really all comes down to understanding the why behind what you're seeing.
So, we're going to break down these 4 big players. By the end of this, you'll be able to spot the differences and, more importantly, know your core nursing priorities for each one. Think of it like pattern recognition, with safety always at the top of the list.
Okay, let's kick things off with our first pair, the neurodevelopmental disorders. You know, ADHD and autism get mixed up a lot, but at their core, they are fundamentally different. The key here is that both start really early in childhood, and they affect how the brain actually develops and works.
I love this slide because it just boils everything down so perfectly. When you think ADHD, your keyword should be dysregulation, trouble regulating attention, energy, and impulses. But for autism, the core challenge is all about social processing and this deep, deep need for routine and sameness.
And this right here, this is the key to telling them apart. The behavior on the outside might look identical, but the reason why it's happening is completely different. So a kid with ADHD interrupts because the thought just pops into their head and comes right out. A kid with autism might interrupt because they genuinely don't pick up on those subtle social cues that tell us, hey, it's not your turn to talk right now.
Okay, NCLEX alert here. You need to know this fact. ASD is way more common in boys. But a little clinical pearl for you. It can look really different in girls, and it's probably underdiagnosed because girls can sometimes be better at masking or hiding their social difficulties.
All right, let's switch gears to our second pair, the disruptive behavior disorders. And let me tell you, the difference between ODD and conduct disorder is something you absolutely have to understand, especially when we're talking about keeping everyone on the unit safe. So here it is, the line in the sand. Think of ODD as a pattern of no. They argue, they defy, they push back against authority. But conduct disorder? That crosses a line into actively violating the rights of other people or major social rules. It's defiance versus downright destruction.
If you ever see this in a chart or in an exam question, your internal alarm bell should be screaming. This is a massive red flag. This isn't just a kid acting out. It points to a profound lack of empathy, which signals a much, much more serious problem.
Okay, so we've pulled these conditions apart. Now, how do we put together a nursing plan that actually works? Let's talk about a simple framework, a kind of universal toolkit that we can use for all of them.
It really comes down to these 3 things. I call them the 3 S's: safety, structure, and support. Honestly, if you don't remember anything else, remember these 3 pillars. They will always guide you to the right intervention.
Your first job, always, is safety. But look how different safety looks for each kid. For the child with ADHD, you're worried about them impulsively climbing on something and getting hurt. For the child with conduct disorder, you're worried about them hurting someone else. You always have to address the most immediate physical threat first. You know, one of the most powerful things we can do is empower the family. Giving them these strategies is a total game changer. And hey, look at that point on ADHD meds. That's pure gold for the NCLEX. Stimulants kill the appetite, so giving them with or after food is a key nursing action you need to know. Okay, let's get into NCLEX mode. Time for a rapid-fire review of the most common traps and the absolute must-know facts for your exam. This is the stuff that separates a pass from a fail. This is such a classic NCLEX trap. A central nervous system stimulant stimulates. It's right there in the name. So giving it at night? That's just a recipe for insomnia. Any answer choice that suggests a bedtime dose is wrong, period.
Oh, that is a big, fat false, 100%. Why? Because threatening or punishing a kid who's already escalated is like throwing gasoline on a fire. It just sucks you into a power struggle. The therapeutic response is always calm, consistent limit setting.
1 in 31. Just let that sink in for a minute. This isn't a rare disorder. This highlights just how important it is for us as nurses to be able to spot the signs early, because we know that early intervention, getting those therapies started, can literally change a child's entire life trajectory.
So picture this NCLEX question. A child on stimulants has lost weight. What are you thinking? Well, you're looking at this chart in your head and you're recognizing a major side effect that needs an intervention. Your first step is to assess their growth chart and then educate that family on giving the meds with food.
Okay, what's your first move? It's always about safety. During a meltdown, that headbanging isn't a choice. It's a reaction to being completely overwhelmed. Your number one priority is preventing physical harm, so you choose C. You gently block the behavior to keep them safe. Then, once they're safe, you can move on to other things like getting them to a quiet space.
And here's a final thought that will help you so much on behavioral questions. Don't get sucked into a power struggle. The right answer is almost always the one where the nurse is the calm, steady anchor in the middle of a storm. Be the thermostat, not the thermometer. This is it, the bottom line. This is your guiding star for priority questions: airway, breathing, circulation, and safety. If someone is physically at risk, you go there first, every single time. Remember that above all else. You've got this.
All right, future nurses, welcome. In this high-yield explainer, we're going to zero in on exactly what you need to know about psychopharmacology for the NCLEX. We're going to cut through all the noise and really focus on the critical safety alerts and nursing actions that are going to make all the difference for you on exam day. And that right there, knowing the difference, is exactly what the NCLEX is all about. It's not about memorizing 1,000 drug names. It's about recognizing those danger signs and knowing precisely how to act. This explainer is designed to give you that framework so you can answer these high-stakes questions with total confidence. Okay, let's dive right in. So we're going to start with the absolute most critical scenarios, these deadly syndromes that can be triggered by some very common psychiatric meds. Recognizing these isn't just a good idea, it's a non-negotiable for safe nursing practice and, of course, for passing your boards. You have to know these cold. Okay, first up, serotonin syndrome. The easiest way to think about this is just a serotonin overdose. Now, for the NCLEX, the key is all about pattern recognition. So if your question tells you a patient is on an SSRI like sertraline and then mentions they were also prescribed tramadol for pain, or maybe that they're taking St. John's wort over the counter, red flags should be going up everywhere. The danger is in combining these serotoninergic drugs. Now, NMS, this is a true medical emergency, and it is a total classic NCLEX topic. The minute you see a first-generation antipsychotic, especially something like haloperidol, paired with symptoms like a sudden, crazy high fever and muscle rigidity, your brain has to immediately think NMS. It's caused by a massive, sudden drop in dopamine. Okay, this slide is so important because the NCLEX loves to see if you can tell these two emergencies apart. They might even give you a scenario with overlapping symptoms just to try and trick you. So let's lock this in right now. If you see the words lead pipe rigidity and a dangerously high fever, you are thinking NMS, especially if there's an antipsychotic on board. On the other hand, if the key signs are those twitchy, overactive reflexes, that's hyperreflexia, and tremors, then you're looking at serotonin syndrome. Let's talk about medications that I call the toxicity tightropes. We're talking about drugs that have a super narrow therapeutic window, where the line between a helpful dose and a harmful, toxic one is razor thin. This number you see here, 0.6 to 1.2, you need to burn this into your brain. This is the magic number, the safe and effective zone for lithium, which is still the gold standard for treating bipolar disorder. If you see a lab value in this range on your exam, that's a good thing. It means the medication is doing its job. But the second that number hits 1.5 or goes any higher, we are in the danger zone. That is a huge red flag for lithium toxicity. The signs can be sneaky at first, maybe just some coarse hand tremors, but they can quickly spiral into confusion, low blood pressure, and even seizures. On the NCLEX, a level of 1.5 or more demands your immediate attention. Now, this is a connection you absolutely have to make for your exam. Think of it like this. Sodium and lithium are kind of like rivals, competing for the same spot in the kidneys. So when a patient gets dehydrated from, say, a stomach bug or sweating a lot, their sodium level drops. The kidneys panic and try to hold on to more sodium, and because lithium looks so similar, they accidentally hold on to more lithium too. That's what pushes the blood levels into that toxic range. And this right here is your patient teaching cheat sheet. You have to tell them that consistent fluid and sodium intake are completely non-negotiable. And the two big no-nos you have to remember for the exam, NSAIDs and diuretics. Both of these can spike lithium levels and cause toxicity. And of course, you have to teach them to report those early toxic signs immediately. All right, so moving on from just toxicity, some drug classes have their own very specific, very dangerous alerts, and you can bet the NCLEX loves to ask about them. Let's tackle two of the biggest ones now. Each has a unique, life-threatening risk you've got to be able to spot. Let's talk about MAOIs, or monoamine oxidase inhibitors. These are really powerful antidepressants, but they are generally a last resort option, and for a very good reason. The NCLEX will absolutely expect you to know that the #1 danger with a drug like phenelzine is a life-threatening hypertensive crisis, and it's triggered by what the patient eats. And this table tells you exactly why. Patients on MAOIs must avoid foods that are high in something called tyramine. See, normally an enzyme in our gut breaks down tyramine, but MAOIs block that enzyme. So tyramine builds up and causes a massive release of norepinephrine, which can spike blood pressure to stroke-level heights. That's why that fancy charcuterie board with its aged cheeses, cured meats, and red wine is a recipe for disaster. And remember, the very first sign of this crisis is often a sudden, severe headache. Here's a really fantastic and easy way to remember those dietary rules. It's kind of silly, but it works. It covers all the big categories: fermented alcohol like wine and beer, aged and fermented foods, and yep, even chocolate. If you see these foods pop up in a question about a patient on an MAOI, you know you're looking at a dangerous situation. Okay, next up is clozapine. This drug can be an absolute game changer for some patients with schizophrenia, but it comes with a terrifying black box warning for agranulocytosis. What that means is a catastrophic drop in white blood cells, especially the neutrophils. It basically wipes out the patient's immune system, meaning a simple sore throat could quickly become deadly sepsis. So when you're thinking about your nursing care for a patient on clozapine, it all comes down to one thing: preventing a deadly infection. That is it. That's your job. That's why the regular blood work is not optional. It is mandatory. They can't even get their next prescription filled without it. And your absolute #1 priority is teaching them to report any sign of infection, a fever, a sore throat, chills, the second it starts. Okay, first up, anxiolytics. These are your anxiety busters. We're going to look at the two big players you have to know. And trust me, they could not be more different from each other. Think of it like this. Benzodiazepines, or benzos, are like a race car. They're super fast acting, which is great in a panic attack, but they come with a high risk of crashing. We're talking major sedation and addiction. On the other hand, buspirone is kind of like the city bus. It's slow and steady, taking weeks to work, but it's way safer for the long journey. This contrast is a classic exam question, so you've got to get this down. And here's a fun way to remember your benzos. Most of them end in PAM or LAM, right? Like lorazepam. So just picture this. Pam takes her lorazepam for anxiety, but she can't drive her Benz anymore because benzos cause sedation. See? The name, the drug class, and the biggest side effect, all locked into one simple sentence. Easy. Now, let's get serious. Benzos can be really dangerous, especially if you mix them with other downers like alcohol or opioids. The #1 risk you have to worry about is respiratory depression. It can be life-threatening, and here's the key fact for your exams. If you need to reverse a benzo overdose, the antidote is flumazenil. Just remember this little phrase: I flew fast in my Mercedes-Benz. Okay, so we've gone through some really specific scary stuff. Let's pull back for a second and build a simple 4-step safety framework. Think of this as a mental checklist you can use for pretty much any psych med question you face on the NCLEX. It'll help you prioritize correctly every single time. Here it is. Step 1, assess. Always get your baselines before you start a new med. Step 2, monitor. Watch for all those key danger signs we've talked about. Step 3, educate. This is a huge part of our job, teaching patients what to expect and what to avoid. And finally, number 4, and this is the most important one for the NCLEX, prioritize. If you have a choice between dealing with a patient's dry mouth or a sudden high fever, you always choose the fever. You act on the most life-threatening problem first. If there is one thing you take away from all of this, please let it be this simple formula. For any psych meds you see on the NCLEX, ask yourself, what is the drug? What is its biggest, scariest danger? And what is my priority nursing action to keep this patient safe? If you can master that connection, you are going to be in excellent shape. Good luck with your studies. You've got this.
Hello, everyone, and welcome. Today, we're going to be diving into two really critical areas in psychiatric mental health nursing: substance use disorders and eating disorders. These are complex conditions, and frankly, your sharp assessment skills and your understanding of what can go wrong can truly make a life-or-death difference for these patients.
So, let's kick things off with a really important question. You know, this is one of those things you absolutely have to know, because unlike a lot of other withdrawals, this one can actually be fatal. By the end of this explainer, you're going to be able to answer this with complete confidence.
So here's how we're going to break it down. We'll start with the essentials of substance use, then get into the clinical response. After that, we'll do the exact same thing for eating disorders. It'll give you a really clear roadmap for both topics.
Okay, let's dive right into our first section. Here, we're going to lay the groundwork, and we'll start by really nailing down the fundamental differences between intoxication and withdrawal. Getting this right is absolutely foundational.
All right, before we go any further, we've got to be on the same page with some key terms. First up is tolerance. Think of it this way. The body gets used to a certain amount of a substance, so it needs more and more to get that same initial effect. Then there's dependence. This is when the body has physically adapted and now requires the substance just to function without feeling sick. And that sickness, that's withdrawal, the physiological storm that happens when the substance is taken away.
Now, this table is just fantastic for seeing the difference side by side. It's all about opposites. So take a look at opioids, for example. When someone's intoxicated, they're sedated, breathing slows, and their pupils are tiny pinpoints. But in withdrawal, everything rebounds. They're agitated, their pupils are huge, and they're miserable. It's the same pattern for stimulants. Intoxication is this euphoric high, and withdrawal is a deep crash into fatigue and depression. Recognizing these opposing signs is a huge part of your assessment.
And this brings us to an absolutely crucial point, one you cannot forget. While opioid withdrawal feels like the worst flu of your life, and it is truly awful, it's not typically going to kill you. Alcohol withdrawal, on the other hand, is in a completely different league. It can progress to something called delirium tremens, or DTs, which can cause seizures, cardiovascular collapse, and yes, it can be fatal.
Okay, so we know the signs, but what do we do about it? That's what this next section is all about. Knowing what to look for is step one, but knowing the priority interventions, that's what saves lives.
All right, when you have a patient in alcohol withdrawal, you need to be systematic and quick. The very first question you should ask is, when was your last drink? This is key because it helps you predict when withdrawal symptoms will peak. You'll use a validated scale, like the CIW scale, to objectively measure severity, which then guides your use of benzodiazepines to keep them safe and calm. And because the brain is so overexcited, seizure precautions are non-negotiable. And here's a classic NCLEX-style tip. Always give thiamine before you give any IV fluids with glucose. This prevents a devastating type of brain damage called Wernicke's encephalopathy.
Okay, let's switch gears to another huge medical emergency: opioid overdose. You're looking for that classic triad: respiratory depression, those tiny pinpoint pupils, and unconsciousness. If you see that, you've got to move fast. So your first move, of course, is to manage their breathing and administer naloxone, the antidote. But listen, and this is so important, your job is not done once they wake up. Naloxone has a much shorter half-life than most opioids. That means it wears off faster, so the patient can wake up, but then, as the naloxone fades, the opioids still in their system can cause them to fall right back into respiration depression. You have to be right there watching them closely, ready to give another dose.
All right, we're going to shift gears now and move into our second major topic for today, eating disorders. We're really going to focus on telling the difference between anorexia and bulimia, because the physical signs tell you so much about what's going on with your patient.
Okay, if you remember one thing from this slide for your exams, let it be this: body weight is the key differentiator. Patients with anorexia nervosa are, by definition, dangerously underweight from severe food restriction. In contrast, people with bulimia nervosa go through cycles of binging and purging, but they are very often at a normal body weight, or sometimes even a little overweight.
So, when you see these signs, you're literally seeing the body's desperate attempt to survive starvation. The heart rate slows way down, blood pressure drops, body temperature falls. It's all an effort to conserve energy.
And that fine, downy hair, lanugo, that's the body trying to grow its own little blanket to stay warm without any body fat for insulation. Now with bulimia, the signs you see are a direct consequence of the purging behaviors. The constant exposure to stomach acid erodes tooth enamel and causes the salivary glands to swell up, giving that chipmunk cheek appearance. You might see calluses on their knuckles, called Russell sign, from inducing vomiting. But the one that can kill them tomorrow, that's hypokalemia, dangerously low potassium. It can cause a fatal cardiac arrhythmia, just like that.
Think of this slide as your select all that apply practice. These are the bright red flags for severe medical instability. Any one of these vital sign abnormalities or a critically low weight means that patient needs to be in the hospital, period. We have to stabilize them physically before any other kind of therapy can even begin.
Okay, so we know what to look for. Now for the final piece of the puzzle. What are our priority nursing interventions, and how do we manage the most dangerous complications? This number you see here, 1 to 2 hours, this is one of your most powerful nursing interventions for a patient who purges. It means you are providing direct, one-on-one supervision during their meals and for at least 1 to 2 hours after they finish. It's not just about watching them. It's about being therapeutically present, offering support, and helping them get through that incredibly difficult post-meal period where the urge to purge is strongest.
This is a huge medication safety alert. You absolutely have to know this one. Bupropion already lowers the seizure threshold on its own. Now add that to a patient who purges, who is already at high risk for seizures because of electrolyte imbalances. It's a perfect storm, right? The combined risk is just too high, which is why it is strictly contraindicated.
All right, let's talk about one of the most dangerous and, honestly, counterintuitive complications in treating anorexia, refeeding syndrome. Here's what happens. When you start refeeding a starved body, the sudden introduction of carbs causes a surge of insulin. This insulin shoves electrolytes, especially phosphate, out of the bloodstream and into the cells, leaving dangerously low levels in the blood.
The absolute hallmark sign, the one you need to have tattooed on your brain, is hypophosphatemia, a massive drop in phosphate. Why does that matter? Well, no phosphate means no cellular energy. Your muscles get profoundly weak. And what are the heart and the diaphragm? They're muscles. That's why you can see deadly arrhythmias and respiratory failure. If your refeeding patient suddenly gets confused, develops swelling, or seems weak, you need to think refeeding syndrome immediately.
Let's wrap this up and bring it all together with some final NCLEX alerts. These are your absolute must-know rules. If your brain is feeling full, focus on these, because these are the core principles that will guide you to the right answer again and again.
Rule number 1 is simple. Safety first. Always. I mean, this is the foundation of nursing, right? Your number 1 job is to keep your patient safe. So it doesn't matter if it's the risk of seizures from alcohol withdrawal, a potential cardiac arrest from refeeding syndrome, or respiratory arrest from an overdose, the most immediate threat to your patient's life is always your first priority. Period.
Okay, rule number 2. Physiology is always greater than psychosocial. Think of it as Maslow's hierarchy, but for the NCLEX. A critical lab value, unstable vitals, a shaky airway, those physiological problems will always take priority over a behavioral or an emotional issue. A potassium of 2.8 is a much bigger deal than a patient refusing to talk. Respiratory depression is a much bigger deal than a patient feeling anxious. Body before feelings. And rule number 3, K+ is key, especially when you're talking about eating disorders. Low potassium in a patient who purges is a cardiac emergency, full stop. Why? Because all that purging wastes potassium. And hypokalemia, that low potassium, can trigger lethal cardiac arrhythmias. So whenever you see a low K+ in a patient with an eating disorder, your brain needs to immediately think, heart. This patient is on the brink of a cardiac crisis. So let's end right where we started. You have a patient with bulimia, a K+ of 2.8, and they're refusing breakfast. Who do you call first, the provider or the dietitian? You have a physiological crisis, that critically low potassium, and a psychosocial problem, refusing to eat. Applying our rules, which one is the immediate threat to life? You know the answer. It's not even close. Your priority is to address that unstable electrolyte and prevent a deadly arrhythmia. And that is how you think like a nurse for the NCLEX.
Hey everyone, today we are diving into a topic that is absolutely critical, not just for passing your NCLEX, but for your entire nursing career. We're talking about behavioral safety and the proper, legal, and ethical use of restraints. Let's jump right in. So put yourself in this situation. You're on the floor and a patient's behavior starts to spiral. They're getting louder, they're agitated, maybe even making threats. You have to act, and you have to act fast. What you do next isn't just a test question. It's about keeping your patient, yourself, and your colleagues safe, all while staying within some very strict legal lines. So what is your first move? Before we even think about interventions, we've got to lay the groundwork. Every single thing we do as nurses, especially in mental health, is built on a solid foundation of patient rights and legal principles. This is the stuff you absolutely have to know. Okay, first things first, let's talk about how the patient got here. A voluntary patient, they walked in on their own and, well, they can choose to walk out against medical advice or AMA. But an involuntary patient, someone admitted because they're a danger to themselves or others, they can't just leave. But here's the key takeaway. Even though they can't leave, they keep almost all of their other civil rights. That's huge. And speaking of rights, these are the big ones that apply to every single patient no matter what. They have a right to confidentiality under HIPAA. They can refuse treatment unless it's a true emergency. And for our purposes today, this last one is so important. They have the right to the least restrictive environment. This means we always have to try the simplest, least invasive options first. Always. Now, about that confidentiality rule, there is one massive exception that you absolutely have to know for the NCLEX. It's called the duty to warn. So if your patient says something specific, like, I'm going to hurt my neighbor Bob, you now have a legal and ethical duty to report that. In this very specific case, the safety of that potential victim, Bob, overrides patient privacy. So with that legal stuff in our back pocket, let's talk about our first line of defense. This is our go-to tool, de-escalation. The goal here is to handle things before they become a full-blown crisis. Honestly, good de-escalation skills can prevent the need for restraints altogether. So how do you know when to step in? You've got to be a bit of a detective. Watch for these early warning signs. A patient who starts pacing back and forth, clenching their fists, staring intently, or raising their voice, those are all your cues. This is your moment to intervene with a calm, therapeutic approach before things go off the rails. And this is how you do it. Think of it as a ladder. You always start at the bottom rung, the least restrictive option. First, just use your words. Talk to them. Show some empathy. If that's not working, try to change the environment. Maybe the room is too loud or too bright. Can you move them somewhere quiet? Next up the ladder, you can offer an oral PRN med. And, it's always smart to call for backup from your team early on. Notice what's not on this ladder? Anything physical. That's way, way down the road. So what happens when you've tried everything on that de-escalation ladder and it's just not working? Only when a patient poses an imminent threat of harm to themselves or someone else do we even consider restraints and seclusion. This is, and I can't stress this enough, the absolute last resort. Okay, NCLEX alert. Get your virtual highlighters out for this one. You can never have a PRN or as-needed order for restraints. It's just not allowed. Period. Every single time restraints are used, it requires a brand new specific order from a provider. No exceptions. This is a huge safety rule. And those orders don't last forever. They're on a strict time limit. This is another thing you just have to memorize. Just remember the 4-2-1 rule. For an adult, a restraining order is good for a max of 4 hours. For an adolescent, it's 2 hours. And for a child under 9, it's only 1 hour. After that time is up, you need a brand new order to continue. And the moment those restraints go on, a new clock starts ticking. A provider, like a doctor or a specially trained RN, has to see that patient face to face within 1 hour. 1 hour. This isn't a suggestion. It's a mandatory, critical safety check to make sure the restraints are truly necessary and the patient is okay. Now let's clear something up. Restraint and seclusion are not the same thing. A restraint is anything that physically or chemically limits a patient's movement. We're talking wrist restraints or a sedative medication. Seclusion is environmental. It's putting a patient in a locked room they can't get out of. Both are serious, last resort interventions with their own strict rules. So you've applied the restraints. Is the crisis over? Nope, not even close. In fact, this is where a period of incredibly intense, vigilant nursing care begins. Your job just got even more critical. This is your non-negotiable to-do list. For a patient in restraints for violent behavior, you're doing checks every 15 minutes. You're making sure you can slip 2 fingers under the restraint to ensure good circulation. You're checking their skin. You're monitoring their vitals. And every 2 hours, you're offering them water, food, and a chance to use the bathroom. Their basic human needs are still your #1 priority. Look, you've heard this a million times, but I'm going to say it again because it is that important. If you didn't document it, it didn't happen. You need to chart everything. The behavior that led to the restraints, all the de-escalation techniques you tried first, every single 15-minute check, every offer of water. Your charting is your legal shield. It proves you acted safely and professionally. All right, let's connect to all of this to the really serious legal stuff. If you mess this up, you could be facing what's called a tort. That's a civil wrong that causes harm to someone. It's so important to know exactly what these are so you can avoid them. First up, we have assault. And here's the thing about assault. No one even has to touch the patient. It's just the threat. If a nurse says, if you don't take this pill, I'm going to hold you down and give you a shot, that statement right there, that's assault. Battery is what comes next. It's the actual unauthorized touching. So if that nurse follows through on the threat and gives that shot against the patient's will without the proper legal justification, boom, that's battery. And finally, false imprisonment. This is exactly what it sounds like, unlawfully confining someone. Putting a patient in restraints because you're short-staffed, or as a punishment. That's not a therapeutic intervention. That's false imprisonment, and it's a huge violation. Here is a super simple trick to keep assault and battery straight in your head for the exam. Just think of the alphabet. A for assault comes before B for battery. The threat comes before the touch. Easy, right? That little mnemonic can definitely save you on a tough question. And I want to leave you with this one final thought, because it really changes how you look at all of this. Our goal as nurses isn't to get really good at putting people in restraints. Our goal is to get so good at connecting with our patients, at communicating, at de-escalating that we hardly ever have to. The use of restraints is not a success story. It's a sign that we have an opportunity to do better. The ultimate goal always is a restraint-free environment. Wow, we have covered a lot of ground today, right? From relationships to disorders, symptoms to strategies. But here's the thing. Memorizing all this stuff isn't the real job. The real challenge is looking past the diagnosis, past the behavior, and seeing the person. So I'll just leave you with this one question to think about. When you're dealing with the most challenging patient on the most difficult day, how do you find a way to connect with the human being in front of you? Because figuring that out, well, that's what being a great psych nurse is all about.